todos, bienvenidos a esta aula virtual número 3 del año 2021, en este espacio de capacitación y de información sobre la ELA que brindamos a la comunidad afectada por la esclerosis lateral amiotrófica en nuestro país. En este caso, el orgullo de presentar a una de las máximas y exponentes líderes de investigación en la ELA, como es la profesora Ángela Genge de Canadá, uno de los países que aporta mayores recursos a la investigación del mundo. Esperemos poder disfrutar de la compañía, de nuestras inquietudes y de sus valiosas respuestas e interiorizarnos y profundizar aún más sobre lo que está sucediendo en la investigación de la ELA, nuestra esperanza para hallar una cura a esta enfermedad.
Well, Angela, you can kick off with your slides.
Well, thank you for this invitation to review where clinical trials are currently in ALS. I'll do a review of what medication are available in at least North America and the clinical trials. And then at the end, we'll discuss where things are with masitinib, which is an important molecule because Argentina has been implicated in the clinical trial program for masitinib. So the first and most important thing to remind everyone is that there are two medications that have been approved in many jurisdictions internationally. One is riluzole or Rilutech, and a recent publication actually suggested that riluzole can have a prolonged effect much longer than the original 3 months. We now think that riluzole may extend life if started early for up to 1.5 years, which becomes an important first step in the treatment of ALS. The second drug on this slide, edaravone, is one that was originally developed in Japan and is now available for patients with ALS in Japan, South Korea, the US, and Canada, with some interest in other jurisdictions, and definitely people in certain other countries can get access. Edaravone was found to slow the speed of progression of patients with ALS and has now been demonstrated to have at least a couple of point improvement or slowing of progression of patients with ALS. The third drug that is now being talked about internationally is one that we call Amylex 0035. It is actually a medication that is a combination of two different medications, one sodium phenylbutyrate and the second TUDCA, or a natural product that we call TUDCA, also known as taurursodiol. The combination of these two medications, which appears to decrease what we call the stress response in ALS, appears to have quite a significant improvement by slowing the progression, particularly in patients that have a fast progressing form of this disease. It was originally studied only in the US. There is a current trial starting in Europe with some sites in the US, but the majority of the sites in Europe. And in Canada, they're looking to see if they can get the drug approved for patients with ALS. So it's an important drug because we have seen this benefit in the slowing the decline of function, slowing the decline of strength, and potentially, and further studies will tell us this, whether or not it has effect on breathing. But a drug that is an oral medication, it is actually something that we can dissolve in water or in any food that the patients can take. And we're pretty excited to see this drug get close to approval in multiple countries. What else is happening? Well, in the world of clinical trials in ALS, we're actually very excited for patients who have genetic forms of ALS. For those of you who have family members with ALS, it is important to know about these trials because the patients are, if you're identified as having a genetic mutation, you can actually participate in a trial even if it's not running in your own country. They've identified a number of sites around the world. Montreal is one of them. And if you have a genetic form of ALS, they will actually fly you to the site as part of the clinical trial in order to participate. This first slide regarding this therapy is about a drug called tofersen. It's a special kind of drug. There are now 5 or 6 of them that work the same way. They're called ASOs, or antisense oligonucleotide treatments. They're given by a spinal tap, and the first one to get close to finishing is this study called Valor, and the drug is tofersen. It is for genetic mutations called SOD1 gene mutations. We have seen tremendous results in the early phases of the trial. We will know this year whether this drug actually slows the disease down for patients with SOD1 ALS. What it does is it blocks the formation of the protein that in the SOD1 patients causes the destruction of the motor neurons. So it's a kind of treatment that blocks the formation of what we call toxic proteins, ASO therapy. This one is tofersen. There is a second one from the same company, and this trial is active again internationally, looking for patients with C9orf72 mutations. These patients are also found in families where there's a family history. This trial and this drug is a little earlier. There are probably a couple more steps before we'll be getting to the final trial. But this particular ASO stops the production of another toxic protein that seems to cause the gene to malfunction and causes the death of the motor neurons. We are actually now at the point where we think we have a level of drug that's going to work, and these patients are continuing in this trial. The third one from this same company treats a third genetic mutation, one called ataxin-2. It's important because it is connected to another kind of neurologic disease that gives difficulty walking, but is not ALS. It's something called an ataxia, a difficulty walking due to loss of balance. This group of patients who have this mutation can present with either this difficulty walking, a spinocerebellar ataxia, or if they have a modified genetic mutation, they may present with ALS. So this program has just started. It's brand new. It's phase 1, so we're a ways away from knowing if it works. But this group of patients have started now with both sporadic and familial forms of ALS being included in this study. A second company that is involved in the field of genetic forms of ALS, Wave, has come up with a way of treating C9orf72 using, again, an ASO, but this company is looking at both ALS and a type of dementia that we call frontotemporal dementia. We are moving forward with this trial. Again, there are a number of sites internationally, 20 in this case, and we're looking at patients who have either ALS or frontotemporal dementia and looking to stop the progression of the disease again. The final dose has not been decided for Wave, so we will be doing that part before we do the pivotal trial where we look for evidence of halting the disease. The third company and the fifth trial using ASOs are is looking at a very, very rare form of genetic ALS, one that is a result of the mutation in the FUS, the FUS gene. Why this is so important is it is one of the most common causes of ALS in very young people. So the youngest I've seen with a FUS mutation was 18 years old when she was diagnosed. And these mutations can cause a very rapid form of ALS. The reason this is so important in clinical trials is this company called Ionis has developed an ASO therapy that they're already testing for in phase 3 to see if it actually can stop the disease progression. This is another international program. And if anyone anywhere in the world is identified with a FUS mutation, the company will fly the patient to the closest site to be able to participate. So again, a really big deal. And it's particularly important if you're a young person who's developing ALS. This mutation is often one that we screen even without a family history, because the vast majority of patients are under 30. So we look specifically for a FUS mutation, and now we have a treatment option that looks extremely promising. Another genetically important trial is this one from ALS Pharma. It's a different kind of drug. It is a monoclonal antibody, so it's given intravenously. All of the ASO therapies are given by spinal tap. This one is given intravenously, and it has been developed to treat SOD1 or mutation patients with ALS that have it as a result of this SOD1 mutation. It again is attempting to clean up these toxic proteins that are causing the motor neurons to die. These toxic proteins are a direct result of the mutation, and the antibody enters the cell and sticks to the toxic protein, enters the bloodstream and sticks to any additional toxic protein, cleans up the toxic protein, and thereby prevents or slows down the loss of motor neurons by essentially cleaning the system of these toxic proteins that are causing the motor neurons to die. This study is being done in 5 different countries in Europe and North America, as well as Korea, and we will have the results, we hope, next year. But it's again really important to know if you have a family history, if you have one of these genetic mutations. We are doing one final program right now, although we expect this to grow larger, where we're looking for patients who do not have ALS, in fact, but have a history of ALS in their family, and someone in their family who died of ALS is known to have a SOD1 mutation. What we're doing in this particular trial is following family members who carry the mutation but have not yet developed ALS. This trial is being led from a clinic in Miami, Dr. Benatar's clinic. We are one of the sites. And what is really important here is if you enter this trial, you will be followed for as long as it takes. The follow-up could be 10, 15, 20 years. We don't know. And what the plan here is that we'll do blood work wherever you are in the world and check to see if there's any signs that you are about to develop ALS. If you have the genetic mutation, those are the only people who are going in. And as soon as we see signs in your blood that you may be developing ALS, you will be then put into the treatment arm. So you're not going to be treated for 10 years without any chance of developing ALS. We wait on the treatment until we have evidence that you're about to develop ALS, and then we'll treat to see if we can actually prevent the onset, or at least keep the symptoms as minimal as possible using this drug called tofersen. So a really important next step in the development of drugs for genetic forms of ALS, because now in this study, we're looking to actually prevent the disease, which is huge in ALS. There are some other programs. Those are the ones that have moved along the farthest, the ones I've just described, but the next series of slides are programs where the drugs are directed at neuroinflammation. This program, the one by the company called Alexion, is now going to finish in the next few months, and we should know by the end of the year whether this drug, ravulizumab, is effective in slowing the progression of ALS. This drug has actually been developed for a couple of other indications or other diseases, including myasthenia gravis. But for this particular trial, because of some results that show inflammation to be important in the progression of ALS, this drug is being tested. There are sites in North America and Europe, and we have finished enrolling for this program, but we expect to have some results by the end of the year. It's not the only trial looking at inflammation as a cause of progression in ALS. And in fact, the next couple of slides are trials that haven't even started in most places in the world. Anelexis has a treatment, another monoclonal antibody directed at another component of our immune system. And its purpose, again, is to slow the progression. We expect these patients to be recruited from all over North America. It hasn't started yet, as I said, and again, looking to slow the treatment down. We're going to be looking at patients for being treated for 11 weeks. There will be several groups. It's the beginning of a clinical program, and we hope to see, again, evidence that neuroinflammation can be controlled and slow the progression of ALS. Meridian, by a company called Apellis, has a drug that works somewhat differently. It actually blocks the entire complement cascade, so it blocks neuroinflammation in a broader level. This trial is also being done in Europe as well as North America, and it's a longer trial. It's a 1-year trial looking at the ability of this drug, APL2, to slow the progression of ALS. It is using only 2 groups. The dose has been already determined, and there will be over 200 patients in this particular trial. And Nexon, I believe, is the final current drug company that is looking to slow ALS by affecting neuroinflammation. It has a different kind of drug, but it is still a monoclonal antibody, so it's still given to patients in addition to patients with ALS. It is still given intravenously, and it's again broadly affects neuroinflammation through complement to slow the disease down. It is a beginning trial. It's a small trial, this one. And so it will only be in a few sites, but it will again show us whether or not affecting neuroinflammation in a different way can control the progression of this disease. Those are the most active trials right now, but I wanted to show you this photo because it shows all the different companies that currently have drugs in the clinic that are really active in a variety of areas. If you look at the top left-hand corner, this is the different companies that are currently involved in the Healy platform trial. Many of you may have heard about the Healy platform trial. This is the US trial that is called a platform trial because there are 5 different medications being tried at the same time. They are not all being tried in the same patient. Each patient who enrolls in this clinical trial gets one of 5 different therapies. The companies are Raw, Selos, Clean, Prolinia, and Biohaven. Each of these drugs has a different mechanism of action. The idea of the platform trial is that the number of patients who get the drug in each arm are far more than the patients who get placebo, because in a platform trial, you can combine the patients who are on placebo and compare it to each of the drugs. So the ratio is 3-to-1 or 4-to-1 drug or placebo. As I said, each of these drugs works very differently. Raw works on neuroinflammation. Clean has gold nanoparticles. Prolinia and Biohaven tackle different parts of the potential causes of neurodegeneration, including hyperexcitability. So you can see that each drug works differently. The patients have the option at the end of their 6 months of treatment to switch to another arm if they think that the drug that they've been on has not helped their disease. So this is an option with the Healy. I'm pointing out Revelatio because this drug looks very promising. And Denali, which has a very specific drug that I think will be seen in a lot of different places. Coya Therapeutics is the one that has the T-Reg program that many of you may have heard about from Dr. Stan Appel. And there's a lot of chatter on the internet. This program is pretty exciting because it is going to show us whether some of the science around T-reg cells actually translates into benefit for patients. I've left a couple other names up there, particularly Curalis, because Curalis is looking at hyperexcitability. And if we treat hyperexcitability, can we control the progression of the disease? I've not included a slide on masitinib, in part because the study is not being performed in Canada. It is moving forward. It has positive results, as you all know, from the last trial. It is continuing with sites around the world, and we hope that with that program that we will get results that will help all patients with ALS. I'm going to thank you for listening, and I'm about to take questions. Thank you.
That was excellent. Well, yeah, we do have some questions from our audience. A ver, ¿quién quiere hacer la primera pregunta para la doctora Angela Gensch? A ver.
Bueno, yo me llamo Santiago Quintero, soy de la ciudad de Merlo, provincia de Buenos Aires, tengo 55 años y hace 8 años que fui diagnosticado con ELA. Y yo he participado en un protocolo cerrado, fui placebo del masitinib, y ahora, hace ya casi 2 años, estoy en un proceso abierto donde estoy tomando el masitinib 300 miligramos por día. La pregunta a la doctora sería, yo lo tomo porque, a ver, la pastilla de 200 miligramos la corto por la mitad, la tomo a la mañana, al mediodía y la de 100 a la noche, por esta causa que acaba la pregunta, porque me produce mucha náusea y en muchos casos vómitos. Y la pregunta sería justamente si han tenido, ya han verificado esto en varios pacientes o me pasa a mí solamente.
So there in the original masitinib trial, nausea, and we saw it in patients here. Nausea was a big component and upset stomach. So absolutely, and this patient's come up with a good strategy to resolve it, because we do think it's because of how high the drug got in the bloodstream. So nausea is a known side effect of this medication.
Yo te quería preguntar, Santiago, aprovechando que vos participaste justamente
Sí.
de este ensayo clínico con el masitinib, que nos cuentes un poco mejor, justamente para que los demás también sepan, porque siempre es una inquietud, ¿no? ¿Cómo hago para participar de algún ensayo clínico internacional? Contanos en qué año comenzaste, cómo fue que te contactaste, con qué centro clínico y de qué país te contactaste al principio, cómo comenzó todo eso.
No, simplemente fui al hospital Ramos Mejía, donde fui atendido por un grupo que es especialista en ELA. Y bueno, me hablaron para participar del protocolo. Por supuesto, previo todo un análisis para ver si puedo o no. Y bueno, los análisis dieron que sí podía participar. Y estuve 2 años de punta a punta siendo placebo. Y después de algunos meses se me permitió, ya llevo 2 años más o menos tomando ya la droga. Y realmente estoy bien, estoy estable, no evito muchos avances. No sé, por ahí manejo, o sea, yo manejo, me fui a la costa en auto manejando yo, por ejemplo. O sea, estoy bien, solamente el habla y las manos un poco, pero lo demás podemos decir que está estable.
O sea, Santiago, que aproximadamente hace 4 años comenzaste con todo esto, entiendo, 2 años de placebo y 2 años con la droga, aproximadamente. Habrá
Con
sido
el
el año.
masitinib, sí, con la enfermedad 8.
No, exacto, con el masitinib, sí.
Sí.
Bueno, sí, el sector de neurología del Ramos Mejía es uno de los mejores sectores de neurología, estimo, del país. Es un hospital
Sí.
público. Ahí está Gabriel Rodríguez, al que conocemos. Y entonces, lo que vos experimentaste con el masitinib hasta ahora, aparentemente, es una estabilización, un
Sí,
amesetamiento.
correcto. Solo con ese pequeño problema de náuseas y vómitos, no son seguidos, pero sí, por 1 o 2 veces a la semana me causa eso.
Antes quería preguntarle a Santiago si en la prueba que le han hecho con el masitinib se lo daban con riluzol. Si también tomaba riluzol, ¿no?
El riluzol nunca dejé de tomarlo. Siempre lo tomé.
¿Y era parte del ensayo que vos sigas tomando el riluzol?
Sí.
Vale,
de acuerdo. Entonces, yo la pregunta que le quisiera hacer a la doctora es, ya que el masitinib trabaja en una dirección y el riluzol trabaja en otra, y las pruebas anteriores han funcionado, no han funcionado bien, no sé si debido a las cantidades o las proporciones, ¿en cuál de las causas que causan daño a las motoneuronas, como es la inflamación, el estrés oxidativo, el exceso de glutamato y todas esas cosas, en cuáles de estos problemas hacen frente conjuntamente el masitinib con el riluzol?
That is very difficult to say. The combination of drugs, the way that the drugs work is really in some ways theoretical. So the combination of drugs, it's very possible that it's the oxidative stress but it's very hard to prove. So we're happy when there's a benefit. We're very happy when there's a benefit, but at this point, we don't know exactly which pathway.
Hace 2 años empecé con síntomas, hace 1 año que estoy con Riluzol y Eradavone. Ya voy, el viernes arranco mi mes 11 de Eradavone. Más que nada mi pregunta es de todos los trials que viene realizando la doctora, ¿cuáles son los que ella cree que van a ser o ve que tengan mayor grado de efectividad? ¿Y qué se podría hacer para poder realizar algunas trials internacionales acá en Argentina con alguna de esos laboratorios?
That's a great question. It's probably one of my favorite questions because I think it's really important that we set up clinics in countries, in new countries that can run these clinical trials. Especially the medications I talked about for the genetic forms of ALS, it is really, really important that we can start opening sites in new countries. We've been able to do it in a couple of new countries, even since these programs started. There are a variety of things that can happen. The most important thing is that you have a clinical trial site, which I believe you do, because you had a site for the masitinib program that is experienced in clinical trials, and that site starts to work with maybe through the alliance, actually, but certainly through the international community to get the companies to bring the trials to countries like Argentina. Argentina is an ideal country to have some of these new trials because you have many trials are already run in Spain, so it doesn't require an additional language. So anything that's run in Spain, in theory, could be run in Argentina because it's already translated in Spanish. In fact, most studies in the US have Spanish translation possible. So that should not be a roadblock for Argentina. It's just a question of how we connect your lead clinicians to the companies so that they're willing to open them up. So I think it's just a matter of working at it. I certainly think there's a lot of interest in having new countries involved in the clinical trials. And I think Argentina should be one of the lead countries, particularly in South America.
Hace 1 año, 5 meses que me diagnosticaron ELA. Tengo 34 años y bueno, mi pregunta para la doctora es si existe intervención emocional del individuo para desarrollar la patología o para la rehabilitación y si es que, ¿qué posibilidad concreta que el paciente reciba acompañante psicoterapéutica es la primera?
So certainly emotional support can be helpful. It's important to understand there are 2 sides of this. One is that emotional support, psychological support of any variety of things can certainly improve the quality of life, potentially help people stay functional longer, able to do things for longer. Certainly, people certainly appear to be able to live longer if they have appropriate support. That's one part of it. So I would fully support that kind of initiative. What I would caution people is to make sure that nobody is in their environments is saying that their ALS is caused by any emotional issue, because it's clear that this is a real neurologic condition. It is not triggered by an emotional stress. It's not a psychiatric type of condition. So the psychological support is really important for how well people do. But the flip side is not true. There's no evidence that a stress can create this quite serious disease.
Y la segunda pregunta sería si a partir de los medicamentos huérfanos se podía considerar la ELA como una patología de diferente grado y por lo tanto crónica, y de esta manera tener una margen más amplia para el trabajo de rehabilitación.
It can be chronic if it's slow. If what you're really asking is could someone consider it chronic so that you can access rehabilitation? So where I practice, you don't need to have it called chronic. Rehab is part of what we do, and it's really part of what we do because we think that the rehabilitation services really prolong people's ability to function. So if you need to use the terminology of chronic to get access to this kind of support, particularly if you have a slow form of ALS, yes. But usually people do not consider ALS as a chronic condition because many patients die within 5 years. So it's not chronic in that sense.
Yeah, maybe we all want it to be chronic in a way.
Yes.
In the future, yes.
Hace 4 años que me diagnosticaron ELA, resido en Catamarca, en Capital, y mi pregunta sería, ¿qué experiencia tienen en la utilización, como en el caso mío, que hice en un comienzo del diagnóstico 13 meses de darabone, y en el transcurso de este año, entre el año pasado y este año, otros 6 meses más de darabone, más riluzol, con la asociación aunque sea interrumpida o no, de darabone, riluzol y esta nueva droga?
So I have not seen patients on all three, but I definitely think that there are certain patients who clearly benefit from riluzole and edaravone, both alone and in combination. Unfortunately, the only way that you can demonstrate that they're really helping is by stopping and then having someone get worse. So I strongly suggest to patients to be on both if they can. We start both as soon as we can here. And the benefit is something that you can't measure. As long as you don't have a side effect of either, you should continue. Both of those medications are allowed in all clinical trials. You do not have to, this is a change. You used to have to stop one or the other or both, and now at least in North America, you have to be allowed to continue both of these medications, even if you enter a clinical trial. The addition of masitinib may help. The most important thing about masitinib is if you get a bad side effect, you have to be very careful. Like your patient with the earlier question, he's resolved it by cutting it in half and using, and this has controlled the nausea. You do not want a side effect to affect your ability to eat or sleep, because we know that weight loss is the worst thing that can happen to an ALS patient. And so if you're nauseated and you can't eat, you start losing weight, that is counterproductive. You don't gain from that. So certainly you continue your riluzole, continue your edaravone, and if you want to try masitinib as well, make sure that you're not having a side effect.
Y otra de mis preguntas sería, además de las reacciones adversas que refirió el señor recién de náuseas y vómitos, si existe, ¿qué otras reacciones adversas o efectos secundarios han descrito ya de la droga?
So there are other reactions. There's lots of problems with your bowels. There are patients who have changes in their temperature. Some people have a rash. So it's like the drug was originally developed for a kind of cancer, and it has some of the same side effects as other cancer drugs. So being nauseated, having trouble with your bowels, your loss of appetite, super common.
Yo quería preguntarle a la doctora si alguna de las pruebas o de los ensayos en los que ella está presente o conoce, tiene algún efecto beneficioso sobre la demencia frontotemporal, que es una de las demencias que se asocian a la enfermedad.
So that's a good question after my talk, because I mentioned it. There's a lot of interest. There are in patients with familial forms of ALS. If anyone on the call has a family history of ALS, we really should get them tested to see what they can, what is available to them. And some of the programs, and I mentioned WAVE, is looking at both ALS and frontotemporal dementia, but I would expect that even more of these therapies are going to do that. I don't think that's the only one. I think we're going to see more. So there's, and that may include the drugs that are looking at the hyperexcitability, by hyperexcitability, what we're talking about is what you see with your fasciculations. If you have lots of fasciculations, that means that your nerves are hyperexcitable. So that's a connection between ALS and hyperexcitability, and why we're looking at drugs for hyperexcitability. But I think that may also be tried in other diseases, including FTD. But again, if you have a family history, if there's anyone who thinks that you have a familial form of ALS, you should look into it more, because in the last 5 years, I've just named 4 different mutations, which we have therapies being developed for all 4 of them. Very important.
So you will definitely, because this is a common question, I'm going to add this question actually. I'm going to take this chance, because we have talked about this with other neuroscientists in our past teleconferences. Do you recommend gene testing for any patient, and also for the families of the family members of those patients?
So I believe that all ALS patients should now have genetic testing. Only if a genetic mutation is found should you consider having the family members tested. But as a result of the talk I've just given, you can see that if you have a SOD1 mutation, even your family members should be tested. So the standard of care needs to change. It will need to change in every country. Different countries will have different ways of getting the genetic testing done, but at least for SOD1, C9orf72, FUS or FUS in young patients, although our current patient with FUS is actually 50, so that's not so young. And the ataxin-2, I think patients need to be tested. I think people who have ALS should have the benefit of knowing if they have a genetic mutation that could be targeted to treat their disease.
Yeah, because it is a common case, like for example, Dario or myself, we had one family member that had ALS in the past. So sometimes we wonder, should we get tested at least for SOD1, just to be prepared in case something comes up?
We certainly can consider it. I have no problems organizing something like that, but the current standard is to test the patients, people with symptoms and signs of ALS, or people who have a strong family history. And then once you have that information, you can decide if other people like you and Dario should get tested. I'm having a lot of people reach out who have had parents, aunts and uncles have ALS. And if I hear of 2 members of the same family with ALS, and even if they have no symptoms and they're much younger, I get them tested. I don't need 10 people in the family to have it. 2 is enough.
La consulta es que implica particularmente que un medicamento esté en fase 3 y por qué los plazos son tan largos en enfermedades que tienen una expectativa o un promedio tan cortos más allá de las excepciones a la regla. ¿Cómo podemos colaborar todos para que eso cambie?
It's a great question. The reason to date that the trials are so long, there are 2 reasons. One is that the regulators want to see trials that long. That's the issue in Europe. It's not the issue in North America. So in North America, you can have 6 month trials. In Europe, you actually have to have 1-year trials. So that's one reason. But the reason underlying that is we don't have a good test that we're sure of yet that will tell us before people lose strength or not that the drug is working. What they're called are biomarkers. But what they really mean is that we have a clue that a drug is working or not working based on something before you lose strength. So right now, all the trials have loss of function as evidence for a drug working or not. That takes a while. What we're looking hard to find is a surrogate or something that can substitute for that loss of function, but earlier. So I give a drug and instead of having to wait 6 months, I see a difference in 2 months or 3 months, and enough of a difference that I can say this drug is working, let's go get it approved. We're not there yet. That's what we're working on really hard right now. So the reason the trials are so long is because in order to see a difference between the group getting the drug and the group that doesn't get the drug, it takes a few months. And unfortunately, that few months is because we're waiting for changes in their physical functioning. And that in a way is too late. We need something better. And what we need is a biomarker, the equivalent of an MRI. We don't have it yet.
Mi pregunta es realmente para saciar una ignorancia propia. ¿Cómo se hace en caso de estas drogas para saber si la evolución favorable en cuanto a la patología, dada que es tan errática, cada uno, como explicaste vos al comienzo, cada uno de los pacientes respondemos de forma distinta, con áreas distintas afectadas, con evoluciones distintas? Entonces, ¿cómo se hace para saber si realmente estas drogas son las que favorecen o detienen o amesetan la enfermedad, o es la evolución propia de la enfermedad de cada persona? Si tiene, ¿qué parámetros de laboratorio, parámetros o parámetros biológicos están manejando con respecto a esta droga para realmente corroborar que haya una evidencia científica de que es positiva para el ELA?
That speaks to the last answer. Right now, the only thing we have is how well people are functioning on the drug versus off the drug. And even with masitinib, that's what we have. It's stated in different ways, but the real fundamental issue is, can you change the course of the loss of strength with the drug you're giving? And unfortunately, that takes too long for a lot of patients. It takes 6 months can be a long time for some patients with ALS. They may lose a lot of their abilities in 6 months. What we need and what we're working on, and why we're doing a lot more spinal taps than we used to, is there is something that's promising that may be able to tell us quite quickly, within 4 weeks or 8 weeks, that a drug is working or not. In riluzole, edaravone, masitinib, and Amylex, all of these drugs that showed a difference, the difference was found in patients' function and not losing function as fast, losing their abilities as fast, and their survival, how long they lived. So they lived longer on the drug than off.
Bueno, la pregunta para la doctora es respecto al AMX0035, que hace poco tiempo hemos tenido respuesta de eso y quería saber cuál es el pensamiento de ella como investigadora del avance de esta droga, y que sabemos que está en fase 3 y que es próximo a tener la posibilidad de acceder o llegar a ella a la brevedad.
Actually, Sabrina Paganoni gave us a talk in March, and she said that the Amylex is applying for drug approval in Canada.
Yeah. So I mentioned that at the beginning of my talk. So so it will depend on where you live, unfortunately or fortunately. So in the US and Europe, there is a new clinical trial, and it is a 48-week clinical trial. It will take a while. In Canada, we will know once Health Canada sees the data what we'll have to do to be able to get this drug for patients. But we're cautiously optimistic that we will be able to, that we may be able to get the drug first in Canada before this latest clinical trial is finished. But if you count the time from when this clinical trial is starting in Europe to when they'll have a data, we are talking at the end of 2022 or 2023 before the clinical trial program in Europe is complete.
Okay, so most likely we may have AMX in Canada first, then in the US, and at last in Europe.
Yeah,
probably, and then the rest. Okay, or we can go through Canada, maybe.
Right.
All right. Yes, we are already talking in contact with people from Amylex to see the chance to start seeing the possibility of getting the drug for compassionate use in Argentina once it's approved somewhere, of course.
Más de lo mismo de lo que estuvieron preguntando, es como repetir, o sea, pero también es saber cómo va el avance en el ensayo, qué oportunidades tiene Argentina de tener el ensayo, pero bueno, es más burocrático que la pregunta en sí.
I think I've shared what I know because it's not going to come to Canada. So they're actively working on setting up the trial in multiple countries. I think the lead physician now is someone from Germany. And I know that they've been working on it for a while, so I don't actually know when the first patient will be in the new trial.
This is a question that I added, but you touched this topic in your presentation. Actually, you know, we had the news recently that the pegcetacoplan trial by Apellis is recruiting, or will be recruiting here in Argentina for the next stage of the trial. So could you give us a comment on this drug?
Well, that's fabulous. I'm really happy. So this means that the efforts are working. So the APL2 and I'll be presenting the trial at the NCALS meeting this week, is tackling neuroinflammation as a cause of the dying of motor neurons in ALS. Regardless of whether neuroinflammation is triggering the disease, there is now increasing evidence that it is part of what causes the motor neurons to die. And this particular drug, APL2, will have a broad effect on a part of the immune system that clearly attacks the motor neurons and the other supporting cells around the motor neurons. And so by blocking the complement system, what we're doing is protecting the motor neurons that are still present. It's not going to create new ones, but any motor neurons that are still present, it will take back the neuroinflammation and allow the motor neurons to function. And so that would be the way that this drug is going to slow the disease. I think it's a great opportunity if you have the opportunity to go into the trial. I think it's a great opportunity to see if, especially when you add it to the approved drugs, riluzole and edaravone, then you're just tackling the inflammatory part of ALS. And so you potentially could really gain some benefit.
It's phase 2 already finished, and now you are moving to phase 3 with this.
It's a good question. It's still a phase 2, but it has the potential to be rolled over into a phase 3. It's still a phase 2, but it's going to give us enough information because it's already a 52-week trial. It has the potential to roll over into a phase 3. They may have to stop and do another trial, but they may not.
I see. Excellent. Great. Yeah, we wanted to talk to you about this, and we've been eager to get more information, but it's great. Yeah. Okay, Angela, thank you so much again for taking your time. It was a great presentation, and it was great to have you here answering questions. And we're looking forward to knowing, to having more news about your exciting trials in which you are involved. And we're going to keep in touch, of course, as always.
Perfect. Thank you so much for listening. Take care now.
Thank you, Angela. Take care. Stay safe.
Bye-bye.
Bye-bye. Thank you so much. Un abrazo gigante a todos. Chao, chao. Muchas gracias.
Saludos.